Intravascular disseminated fungal infections are an important cause of severe morbidity and mortality in immunosuppressed patients, and with the frequency of transplantation and the problems associated with HIV/AIDS and other causes of immunosuppression, they're more commonly encountered nowadays than they were in the past. And this is an absolutely beautiful example of Fusariosis, which was shared with me very kindly by Dr. Vicktoryia Kazlouskaya of Pittsburg University, and we're looking at it on the Kiko platform. And at slow power or scanning magnification, the features are very dramatic. The vessels in the dermis and going down into the subcutaneous fat are intensely dilated and congested, with a surrounding marked dermal edema. And even at this magnification, you can see there are large numbers of spores or conidia in the dermis, and also in the erector pili muscles, and they're also present down in the subcutaneous fat. So if we look at this a little bit more closely, let's just zoom in and see what's going on. I mean, isn't that just such an amazing histological field? It's just mind-blowing. There are thrombosed vessels, intensely congested vessels. The dermis is stuffed full of conidia, and even at this magnification, you can see scattered hyphae. I'll zoom in a bit. Let's see, we'll get our maximum zoom there, and you can see, isn't that just beautiful? I've seen quite a few cases of intravascular fungal infections in the past, but nothing is anywhere near as dramatic as this case. It's absolutely amazing. And you can see there are septate hyphae scattered around the place, and within the vessels and also in the dermis are very large, conspicuous, thick-walled spores or conidia. And what is really striking as well is the virtual absence of any inflammatory response whatsoever. And this is what you expect to see in patients suffering from systemic intravascular fungal infections. Sometimes Fusarium infection can occur as a consequence of implantation, say from a thorn prick or in a burn or after a road traffic accident. And when you get that, you tend to get a suppurative and granulomatous reaction. Now, I'm just going to zoom out because this other piece of tissue, I think, will show us the branching pattern a little bit better. I'll just bring it up to maximum, and then we'll be able to have a look. And that's our best. If we look here, we can see large numbers of hyphae, and occasional branches are seen. There's acute angle branching there, and acute angle branching here. Now, Fusarium species, they branch at anything from acute angle right through to 90 degrees. And this is one of the ways that they differ from Aspergillus. Now, I've seen quite a few Aspergillosis cases, and I've never seen this degree of sporulation. So it would not be, it certainly wouldn't be my first thought. But having said that, I think it's a mug's game trying to identify a species of fungus on the basis of the H&E, and I think it's much wiser wait until you see what the culture is. And sometimes you may need even to do PCR to identify which particular species has infected the patient. Now I'm going to come out of Kiko and go to a short PowerPoint presentation which I thought would be useful just to talk a little bit about intravascular fungal infections. Now, all sorts of fungi may be involved, but the ones we see most commonly are Aspergillosis, Fusarium infection, as we've been looking at, Scedosperium, which in the old days we used to refer to as Pseudoallescheria most often, but new terminology changes, and so I'm keeping up to date for this presentation. And occasionally we also may see Mucormycosis, and I'll show you some examples of each of these. A term that's often used in the books are Hyalohyphomycosis, and I just wanted to touch on that to define it. These are non-dermatiaceous, which means they are non-pigmented hyaline branching septate hyphae. And they include most commonly Fusarium species and Scedosperium species. And by definition, we exclude Aspergillus, Penicillium, and Mucorales. Now, a little summary of Fusariosis. A variety of species may be seen in the skin or in the systemic cases, but most commonly Solani, Oxysporum, moniliforme. And this fungus is ubiquitous in the environment, and patients may inhale the fungi and develop systemic disease, or sometimes, but much less commonly, that direct contact with the spores or conidia can complicate patients with burns following trauma such as road traffic accidents or penetrating injuries from thorns. And as I've mentioned, the hyphae, they branch at anything from acute angle to 90 degrees. And this Fusariosis is one of the fungi in which conidia are particularly present, as was dramatically shown in this case. Now, one of the differential diagnoses is Scedosperium boydii infection. And again, this is a ubiquitous fungus. It's found in soil, water, and plants. And the cases that I've encountered have been complicating pulmonary infection with systemic spread. And I couldn't find my cases of Pseudoallescheria, but I've copied one from my book, and this is obviously courtesy of Elsevier. They're very, very similar to Fusariosis, and one can only make a positive diagnosis after culture. Now, Aspergillosis is the most commonly encountered systemic fungal infection in immunosuppressed patients. I love this photograph on the right, which was very kindly shared with me many years ago by a great friend, Randy Margolis from Boston. And this shows you from the derivation of the term Aspergillosis. It's so named because the spores have an appearance reminiscent of the shakers that you are used in the church for shaking holy water, and so this is called the aspergillum, and so the fungus is therefore called Aspergillosis. And it presents as a pulmonary infection in immunosuppressed patients, and much less often we can see it as direct inoculation. And it's a problem. It's a ubiquitous fungus. I apologize for the spelling mistake there. That should have read soil and organic debris. And as many of you know, it's commonly present in bird droppings, particularly pigeons. And this is a lovely example on the right. It's showing intravascular hyphae extending outwards into the dermis. And Aspergillum typically branches at 45 degrees at an acute angle, and it has an arboreal or tree-like growth pattern. But to be honest, one cannot be absolutely sure that one's looking at Aspergillus rather than Fusarium or Scedosperium, so we do need cultures. Here's a close-up view of Aspergillus. It's an absolutely beautiful histology. And this growcott shows you very nice septum formation in those hyphae there and there. And this shows us the branching pattern at an acute angle. There's a septum there again. And lastly, I just wanted to touch on Mucorales species, which includes Rhizopus, Mucor, and so on. And again, these are ubiquitous fungi. They're present on fruit and vegetable matter. And mostly when we see them, their patients are extremely ill, and the disease is generally fatal. But again, you can sometimes see localized disease due to inoculation following plant contact with thorny plants or with intravenous drug use and the like. And here we have a close-up view. Mucor is much broader than Aspergillus and Fusarium and so on, and they are non-septate fungi, and they often have a rather twisted appearance, and even though it's a vascular spread, they often are associated with acute and granulomatous inflammation and can in fact resemble paniculitis. I have one lovely case that when I looked at it first, I thought I was looking at pancreatic fat necrosis, but fortunately I looked at high power and came across some fungal hyphae, and the special stains, it really showed up very, very dramatically. And this is an example here of mucormycosis. This is a large vessel, and you can see the vessel wall is completely riddled with hyphae, and there's a surrounding suppurative inflammatory reaction. And there's that close-up view that we looked at earlier. And here's a silver stain showing numerous fungi both within the lumen of the vessel, throughout the wall of the vessel, and extending into the adjacent dermis. So in conclusion, I just want to remind you that systemic fungal illness are something you have to keep in the back of your mind when you get a biopsy from an extremely ill patient, and to remind you that even with the use of special stains to show septum formation and an angle of branching, you really do need to culture the specimen, and sometimes even molecular techniques are necessary before you can come to a definitive diagnosis. Thank you very much.